Order, order. Ronnie Cowan to move the motion.
Thank you very much, Ms Ryan, and nice to see you again. Let me start with a few undisputed facts. Drug deaths due to overdose are increasing year on year in the United Kingdom. People have been taking drugs of various types for thousands of years. In the last 100 years or so, we've run a campaign to criminalise, persecute people that take certain categories of drugs. We decide what drug does or does not belong in a certain category. Some criminals have become staggeringly rich through their involvement in the production and supply of drugs. Users are stigmatised as junkies, crackheads and stoners. Society adopts this language to dehumanise and ostracise sections of a community. This facilitates their abuse and allows them to be used as scapegoats. So where are we now? The drive to arrest and incarcerate the producers, distributors, dealers and users, often referred to as a war on drugs, has seen a massive increase in violent crime and corruption, along with hundreds of thousands of deaths and the criminalisation of some people for the most minor offences. The perceived problem that the war on drugs set out to solve has in fact been compounded by the war. As a result, time, money and lives have been wasted.
Called. The sitting is suspended until this series of votes is concluded. When that series of votes is concluded, the sitting will be resumed 5 minutes after the announcement of the result of the last vote in this series. Order, order. Mr Ronnie Cowan.
Thank you very much, Ms Ryan. And as I was saying before we were so rudely interrupted, we created this situation and we can fix it, but it will take a change in attitude at governmental level to do so. Rather than paying lip service to people with an addiction, we need to start listening to what they are asking for. We need to treat addiction as a health issue, not a criminal justice one, not just in part, but in its entirety. One part of the solution is drug consumption rooms. Supervised drug consumption facilities where illicit drugs can be used under the supervision of trained staff have been operating in Europe for the last 3 decades. These facilities primarily aim to reduce the acute risk of disease transmission through unhygienic injecting, prevent drug-related overdose deaths and connect high-risk drug users with addiction treatment and other health and social services.
On that point?
Certainly.
For giving way, but would he agree with me that indeed one of the big strengths of DCRs is precisely in reaching those people with drug addiction problems who aren't otherwise known to the services? In other words, if we can begin to build relationships with them over time, then when that trust is there, it's much more likely to be able to get them into the kind of services to begin to really address the reasons for the addiction.
I completely agree. It's one of the steps in the beginning of the healing process. If you can build a working relationship with people and earn their trust as they'll come back for you without the suspicion which we've built around drug users in general. They also seek to contribute to a reduction in drug use in public places and the presence of discarded needles and other related public order problems linked with open drug scenes. Typically, drug consumption rooms provide drug users with sterile injecting equipment, counselling services before, during and after drug consumption, emergency care in the event of overdose, primary medical care and referral to appropriate social health care and addiction treatment services. Currently, people are sharing needles, using a product that may kill them instantly and living a chaotic lifestyle that harms them, their friends and their families. DCRs provide needles. Instantly, we reduce the spread of HIV and hepatitis C. Instantly, we improve the health of the user, and instantly we engage users back into society where they can be signposted to relevant services. Needle exchanges also go some way to doing this, but as the paraphernalia leaves the premises, it's often discarded in public places or shared with other users, and users may choose to inject themselves in streets, doorways or gardens near to the exchange. This is unsuitable for the users and the local residents. But the great thing is that we have evidence from 10 other countries that DCRs work. The first supervised drug consumption room was opened in Bern, Switzerland in June 1986. Further facilities of this type were established in subsequent years in Germany, the Netherlands, Spain, Norway, Luxembourg, Denmark, Greece and France. And outside Europe, there are facilities in Australia and Canada. A total of 78 drug consumption facilities currently operate in 7 EMC DDA, European Monitoring Centre for Drugs Addiction, reporting countries. I'll give way.
I'm grateful to the Honourable Gentleman for giving way, and I congratulate him on securing this important debate on a potentially a controversial subject, but perhaps one that we need to really look at the evidence. And would he agree that not only are there health benefits, but there are benefits in terms of crime prevention and reducing crime? The Home Office's own figures say 45% of crimes are caused by drug users stealing in order to feed their habits, and there will be considerable benefits in terms of tackling that through the introduction of consumption rooms.
Absolutely. The closest thing we've had to this, in my knowledge, in the UK was opened by John Marks in the Wirral back in the 1980s, and at that time local crime dropped by over 90%. We have the information at our fingertips. But most interestingly, no country that has adopted a DCR have ever regretted it and subsequently closed them. Switzerland and Spain have closed DCRs, but only because the need for them reduced significantly. They were so successful that they put themselves out of business. Before the festive recess, I asked the Prime Minister at PMQs to change the law to facilitate DCRs in the UK. And if she won't do that, then devolve the relevant powers to the Scottish Parliament so the Scottish Government can do so. The law needs change to protect the people that supervise the rooms and enable the relevant police forces to take a consistent stance which does not set them apart from the rest of the judicial system. Certainly.
I'm very grateful to, like my friend has just spoken, I think the evidence is really important on these issues. I'm confused about the position in Scotland where criminal justice is devolved. And the Honourable Gentleman has just referred to the devolution issue. Can he clarify for me, I'm genuinely interested in this, why this step has to be taken by the UK Parliament?
There are certain aspects of the law which are not devolved to Scotland. The laws we require, so as people can work in these facilities with impunity, still rest here at Westminster. So I want those laws devolved to Scotland, because we have the appetite there to do this job. President, 1 minute. The Prime Minister's response was that she knows some people are more liberal about drugs than she is, but she's not minded to do anything, which completely misses the point. This isn't about a liberal attitude, it's about compassion and treatment for vulnerable people.
For giving way. Before we move too far away from law enforcement in Scotland, can he explain, if you were to get these powers devolved, what would be the police's response? Would they be asked to, ignore people in possession on their way to these venues, regardless how far away from centre they were?
What this would do would give the police the authority to stay within the law. We're not asking them to turn their eye on people who are breaking the law, but the laws would allow people to carry in their own drugs. The limit from which you can carry a drug has not at this point been defined. The point is that the Scottish Government and the Lord Advocate has asked for this facility to happen. The alternative would be that we've got people shooting up in alleys and contracting HIV and hepatitis C. If that's the alternative that you want to see in Scotland, it's not what I want to see anywhere within the United Kingdom. So nobody is saying that drugs are for everybody and that drugs are great. What I and many others are saying is, if we want to stop damaging society and help the many individuals that have a drug addiction problem, then we need to change our approach. DCRs are not a magic wand or a silver bullet. They will not resolve every issue. Let me start with a few undisputed facts and cost-effective. Drug deaths due to total operating costs increasing of the Glasgow Safer Drug Consumption Facility and heroin people have been taking drugs of various types for £2.5 million per annum. In the last 100 years or so, we run a campaign to criminalise 2006 persecute people that take illegal drugs in the Scotland around £3.5 billion. What drug does Vancouver Insight DCR cost the Canadian taxpayer some criminals will become staggeringly rich through their involvement for every dollar spent, four are saved as they are preventing users are stigmatised as junkies further down the line. And stoners figure recognised in many other countries. In 2011, ruling the Supreme Court of Canada concluded that facilities Vancouver Insight safe injected and saved lives with no negative impact on public safety in the neighbourhood. The drive to arrest and incarcerate overdose deaths were distributors, dealers and users often referred to as a
study
war
in
on
Sydney
drugs, showed that there was a massive increase in violent crime and corruption, along with hundreds of thousands of deaths and the criminalisation of some people for the most minor offences. More like the perceived problems that the war on drugs set out to solve has in fact been compounded. These findings corroborate other investigations as we go an essential step towards preventing the marginalisation and the stigmatisation. NHS GGC estimate that the annual cost of the taxpayer of each problem drug user is £31,438. They further estimate that the introduction of a new heroin-assisted treatment service could save over £940,000 of public money by providing care for just 30 people who successfully engage with the treatment. So even if we didn't give a damn about the people with addictions, it makes good financial sense to provide these facilities. It is more cost-effective to provide DCRs than it is to pick up the bill after the damage has been done. DCRs are more than just a practical solution. They are humane, compassionate and financially effective. I can think of about 2 reasons why the UK Government is so resistant to this proposal. Either they are stuck in an ideological mindset that people with addictions are not ill, they are the product of poor lifestyle choices, or the UK Government simply doesn't care. The UK Government has stated it is for local areas in the UK to consider, with those responsible for law enforcement, how best to deliver services to meet their local population needs. We are committed to taking action to prevent the harms caused by drugs use, and our approach remains clear. We must prevent drug use in our communities, help dependent individuals recover, while ensuring our drug laws are enforced. This cowardly stance simply underlines the UK Government's disengagement from the reality of the situation. It pushes responsibility onto the shoulders of local administrations and the police force, who are refusing to furnish them with the legal powers to act responsibly within the law. Home Office-led international comparator study in 2014 concluded that there was some evidence for the effectiveness of drug consumption rooms in addressing the problem of public nuisance associated with open drug scenes and in reducing health risks for drug users. The EMC DDA, European Monitoring Centre for Drugs and Drug Addiction, considers that on the basis of available evidence, DCRs can be an effective local harm reduction measure in places where there is demonstrable need. But despite that evidence that financially DCRs are viable, the United Kingdom's government has chosen to ignore the evidence. Can the Minister please tell me why? And in conclusion, I shall once again ask, will the UK Government look at the growing body of evidence and change the law to allow DCRs to be opened in the UK without fear of prosecution, or will the UK Government devolve their relevant powers to Scotland to allow the SNP Government to pursue ambitious and innovative new methods to tackle the public health issues of unsafe drug consumption?
Consumption rooms. Douglas Ross.
Thank you very much, Mrs Ryan. It's a pleasure to serve under your chairmanship, and can I also thank you for your understanding that I'm unable to stay until the end of the debate, but was still able to be called. Could I congratulate the honourable member for Inverclyde for securing this debate, but say from the outset that I am against the introduction of these facilities. The problem with support for drug consumption rooms is that it's based on a faulty assumption that the issue with Class A drugs is the circumstances in which they are consumed. It is true that many users of Class A drugs are killed, injured or exposed to infection by particularly unsafe means of consumption, such as, for instance, dirty needles. However, the answer is not to create state-sanctioned drug consumption rooms. The answer is to address the real issue, which is the consumption itself. Our efforts must be focused on getting people off these drugs. Diversions like drug control rooms only serve to distract from the purpose or even make matters worse. And I will give way.
Thank my honourable member giving way, and want to congratulate the honourable member for bringing the debate today, which I would have done had I had the chance to intervene on him earlier. But my honourable member makes the point about helping people to get off of drugs. Well, surely the first step is engaging with those people with medical services, and actually the purpose of these rooms is actually to do exactly
that and help people to engage in a safe way, and that could be the first step to getting them off the drugs.
I don't disagree that engagement is important, but I do disagree that the only place that engagement can take place is in these drug rooms. And I would stick by what I said earlier on, because we really have to ensure that we do not go down this route, because there is ultimately no safe way to take a Class A drug. That's why they are classified as A drugs. In a moment, someone may use the drug consumption room once. They may even use it regularly. But there is no guarantee they will use it all the time. Because as long as someone is addicted to these drugs, you cannot keep them safe. You certainly can't set them on a course towards recovery and the drug-free life that every human being deserves. I think we're short of time, so I do want to keep going. Drug consumption rooms could even make things worse. Some drugs, such as heroin, work in a way that many people build up a tolerance to them. So in order to get the same high to satisfy their addiction, they end up having to take more and more of the drug. So we could be faced with the prospect of the state building a facility to passively watch over someone sinking deeper and deeper into addiction that, with each hit, becomes more and more likely to kill them. Instead of building drug consumption rooms and trying in vain to make addiction of these drugs safer, we should be redoubling our efforts towards helping people overcome their addictions altogether. And when it comes down to it, the only safe approach and the only thing we should be encouraging is detox and abstinence. That also has the added benefit of being less regionally biased. I, for one, can't exactly foresee many drug addicts in Murray, where I represent, making use of a drug consumption room in Glasgow. But drug addiction is not limited to the large cities or the communities close to them. It's an issue that affects all parts of the country, including small and relatively remote rural communities like my own. There may be fewer addicts in Murray than in other parts of Scotland, but they deserve the same level of support. This issue should not be reduced to a postcode lottery. I will give way.
This is an issue where members of this House and members of the public have strong feelings. So I think it's important we consider the evidence and the arguments. But just in relation to shooting galleries, I'm not familiar with the position in Murray, but what I do understand is that shooting galleries exist. And to say that you're against drug consumption rooms, what's happening in my constituency is they're located in private dwellings with drug addicts using dirty needles and tainted drugs of unknown quality and strength. So why would the honourable member believe that dangerous private shooting galleries are preferable to drug consumption rooms?
Remarks by saying we must make our decisions based on evidence. So the evidence from Professor Neil McKegney, founder of the Centre for Drug Misuse Research, said, we surveyed over 1,000 drug addicts in Scotland and we asked them what they wanted to get from treatment. Less than 5% said they wanted help to inject more safely, and the overwhelming majority said they wanted help to become drugs-free. So that's the evidence I'm looking at. Now, I also just want to explain further what I was saying about how this impacts more rural areas. The opioid epidemic in the United States has shown us just how drug addiction crises can become dispersed, largely rural phenomenon, rather than something that is confined to parts of cities within reasonable distance of a drug consumption room. There are, of course, other issues. Take policing, and this is an issue close to my heart, given my wife is a police officer. Obviously, we could not have police standing outside a drug consumption room ready to arrest anyone who walks in for possession. But then where do we draw the line? Do we have an exclusion zone where the police don't arrest for possession? What about if someone's further away, as I was trying to say to the Honourable Member for Inverclyde, but still claims to be en route to the consumption room? Do you prosecute them? Could it even be used as a valid legal defence if, after all, the government is the one actively setting up these places where drug possession and consumption is condoned? It sets us on the road to a sort of selective decriminalisation. I know the Honourable Member for Glasgow Central and the SNP want powers over drugs, including the Misuse of Drugs Act 1971, to be devolved to the Scottish Parliament. But I believe the UK Government is correct to expect the police to enforce the law, and I don't support this matter. What we all want is to help drug addicts. What we want is to bring addiction levels down, reduce the number of deaths and injuries and cut the crime rate. But drug consumption rooms are not the best way to do this. The best and right thing to do is to enforce the law and focus on getting people off drugs altogether. Thank you.
Thank you very much. One of the clearest failings in public policy has been the war on drugs. Treating addiction and addicts as criminals has clearly failed. It doesn't work. It has led to 3,744 deaths last year alone. And if people think more enforcement will work, I'm afraid they are sadly deceived. The evidence around the world shows time and time again that DCRs are a way to help people stop taking drugs. DCRs are places where people can engage safely. Let's, for example, take Sydney. In 1999, the King's Cross area of Sydney was known particularly for its large overdoses and deaths. In many respects, very similar patterns to what I sometimes see in parts of Brighton and Hove in terms of within a British national picture. I remember Sydney at that time, and I remember visiting there myself, and it was a problem. Drug consumption rooms were trialled, and after 10 years, an independent report was commissioned by KPMG. What did they find? In those 10 years, not one single fatality from any of the users who had attended the rooms. Let me repeat that, because I think actually some of my friends and colleagues don't seem to get that's the difference. In Sydney, where there were 4,400 drug users, not one single had died, and in Britain last year, 3,744. Now, I know which system I would prefer, the one where there are no deaths on my hands. And I'm afraid the reality is people who advocate for a cracking down are advocating for the deaths of sons and daughters and friends and family. And that is the reality. That is the cruel reality of the policy that we have at the moment. Yes, go ahead.
The introduction of DCRs in Sydney, are you saying there was no drug deaths whatsoever as a result of the introduction, or was the no drug deaths related to users of the particular rooms?
No, the KPMG study found that there were no drug deaths of people who had used and engaged in the rooms. Now, I'm not going to come back, but engaged in the rooms, of which there were 4,400 people who engaged over that time. In terms of the total number of ambulance call-outs, in total on drug issues in Sydney during that period, an 80% reduction. It reduced the average number of overdoses in public locations by more than 3/4. It provided 9,500 referrals to welfare services in the wider community. And most importantly, it won the support of residents and neighbours. Because one of the things that we hear time and time again in this argument as well, and I'm sure it will be brought up, is that people don't want it in their backyard. Well, the reality is, actually, as we've said, colleagues have said to me previously, at the moment it is in your backyard, quite literally. I remember canvassing and up flights of stairs, in tower blocks, people right in front of me, shooting up, nowhere to go, no support that could be offered. The only thing that potentially could be do is to ring the police, and you know that in a day or so, the revolving door will all start again. How does that help with the pressure on our police? How does that help with actually the pressure on our communities? The reality is that it doesn't. Now, globally, there have been two tracks that countries have gone down: the prohibition track or the treatment track. And also, globally, at the same time, in all of those jurisdictions, usage has actually slightly decreased. But what has happened is the harm caused by harder drugs has rocketed in jurisdictions that go down the prohibition route, and people being stuck into long-term habits increases under the prohibition route. Under the treatment route, as we've seen in Portugal, etc., etc., you see actually long-term usage go down, and you see the harm slashed. And surely that is what our policies must be about. The harm to communities and the harm to individuals. Now, I don't want to speak for much longer because I know lots of other colleagues want to come in. I do just want to touch on some of the other issues that were raised by some of the colleagues here about policing. Because I feel it is a slightly, maybe, I don't know, a straw man kind of argument, really, about the policing issue. Now, if you have a centre where you're asking for people to come in for treatment for abstinence, a centre for people to come in to stop their addictions entirely, do you stop all of them coming in to the centre on the off chance, because they are addicts, that they might have drugs on them? Do you follow them home? Do you try and entrap them? Well, we don't do that at the moment. We don't. And so actually suggesting that the police would need to do that with DCRs, I think my view is a complete straw man argument. Now, of course, I will come. Of course, no law is perfect. And of course, there are areas where there are grey zones. But surely it is better to work where there are legal grey zones and issues that we would need to deal with dialogue with the police and save lives, than have a system where we have a hard and fast rule and thousands of people die, 56 in Brighton and Hove, which is actually lower than in previous years in my city. And my honourable friend from the other part of my city is here as well, and I'm sure she will testify. Go on.
Police were going out and searching everyone on the way in. What I was suggesting, that there is a reasonable concern that if someone in the vicinity of a drug room was stopped and searched and found to be in possession of something like heroin, they could say they are on their way there in the future, and therefore they may not be charged. And that is the reason why the Lord Advocate in Scotland was not able to give his permission for the example in Glasgow.
Interesting. That doesn't seem to be a problem elsewhere. That's all I can say. Doesn't seem to be a problem elsewhere. Let's base it on evidence. Let's base it where it's based elsewhere. Look, I've spoken for long enough, and I'm going to give way. Thank you.
Just want to make sure that you weren't taking intervention from your colleague next to you, but I'm very grateful to be called, and I'm delighted to follow the Honourable Member for Inverclyde and congratulate him on securing this debate, and recognise that we have a shared interest in the work that we jointly do as officers of the Drug Policy Reform All-Party Group. And I largely agree with his analysis, and he will be unsurprised to hear. My honourable friend from Murray might be a little more surprised about that, but I congratulate him on his speech and taking part in this debate and representing a view that is indeed in Parliament would appear to represent the current view of the majority, and it's an example of the challenge one faces if one is to get consideration of this issue into the era of evidence and to get it addressed around the issue of public health. And my honourable and learned friend, who is speaking for the government here, is entirely typical that as a Minister of the Interior or Home Department of nearly all the nations of the world where drugs policy sits. And that is frankly wrong. It ought to be sitting where it is in health. It is a very serious health issue that we're dealing with here. And much as it would be very nice if the efforts of the world to deliver detox and abstinence was a realistic objective, which is the one elucidated by my honourable friend for Murray. Well, the world has been trying to do this now collectively for very nearly 60 years, and the position continues to get worse and worse and worse. The criminal justice consequences, and this is where I come from my experience, having served as Minister for Prisons and Probation and Criminal Justice for 2.5 years. The criminal justice consequences of this policy are utterly appalling. And that is just in the United Kingdom. Half of acquisitive crime is driven by addiction. And if we can't do anything around addiction, we should be not remotely surprised that the cost to our country of the criminal justice impacts of this is the order of £13.5 billion, I think was the figure given in the government's latest drug strategy. And in coming to this issue, from a criminal justice perspective, my view was that I would have traded the massive savings you make around criminal justice if you can get this issue out of the criminal justice and then into being addressed on those of public health. And what has, as I have got into this issue and understood it better, actually is that these two things go hand in hand, and you will get a significant public health advantage by being more transparent and more open about your treatment of addiction. And even if one is not going to be prepared to go outside the global convention and the global policy about the war on drugs and go as far as Portugal has gone, simply around decriminalisation of the low-level users, you see a massive improvement in your public health outcomes. I'm happy to
thank my honourable friend for giving way, and he's making a characteristically constructive and well-informed speech about the matter which he knows well. Would he agree with me that one of the problems is that the current approach, by punishing people who, through addiction, are effectively medically unwell, at least that's the way that I would see that as a doctor, we're actually worsening the ability to engage with them effectively in healthcare terms, and we're actually worsening the spiral of addiction in terms of debt and the criminal justice consequences, and that needs to change.
I wholly agree with my honourable friend, and with his medical background. Again, he speaks with authority on this. And drug consumption rooms, plainly, on the basis of the evidence around the world, ought to be part of our attempt to treat those people who find themselves in the wretched position of being addicted to the most difficult and dangerous drugs. And it's simply the evidence. If no one has died globally in a properly overseen drug consumption room, and yet in our country in 2016, out of the 1,707 people died as a result of illicit heroin use. And if you look at the extraordinarily stark contrast in the figures between Portugal and Scotland, those figures alone ought to be considering all of us to think very carefully about what the implications of our current policy are.
I hope, however, the honourable member will agree, while no one has died within a drug consumption room, that doesn't mean anyone who has ever used a drug consumption room has not died as a result of drug taking. Because, as I said in my speech, we can't get everyone to go every time. Some go once, some go every now and then, but we cannot enforce them to go every time.
Of course my honourable friend's right, but I'm not entirely sure what the merits of his point are. What we...
well, it doesn't solve the problem.
Well, it has, when he, honourable friend from a 70 position, it doesn't solve the problem. The truth is, we are never going to solve the problem. Humanity has been using drugs in one form or another for thousands of years. My honourable friend almost certainly uses a drug unless he's a teetotaler, then he's frankly in quite a rare position. The vast majority of certainly of members of this House use a drug perfectly legally, and the drug is called alcohol. It happens to be the drug that the Advisory Committee on the Misuse of Drugs said is probably the most dangerous drug in use in the United Kingdom in terms of its impact. He is a football referee, and having seen football crowds, will know the difficulty of policing crowds under the influence of alcohol. Alcohol is quite a significant and a difficult drug to I give way to the honourable lady.
For giving way, I mean, he mentioned the Advisory Council for the Misuse of Drugs, and of course that body has itself recommended that this is a policy, DCRs is a policy that we should pursue. But would my honourable friend agree that not only is it the case that DCRs haven't been a venue where people have died, it's also the case that they have been one of the most effective interventions at getting people away from addiction. DCRs are not being complacent about addiction, they're being realistic.
We've got two more speakers, and they will be able to get in. We'll be coming back immediately. Everybody is back from the vote. We won't take the 15-minute. We'll start immediately. Everybody is back. If there are two votes, the same will apply. As soon as the second vote is done, I think there is one, then if everybody could get back quickly, except for honourable members who've already informed me that they can't. Order, order. Crispin Blunt.
For the interrupted speech. And all I really want to conclude by saying is to say one should recognise the challenge facing the Minister in the circumstances she's got. It is difficult enough where our policy is stuck within a place where I believe global policy is in absolutely the wrong place, 60 years of the policy not working. She's got to then deal with the legislative framework that she has to operate within, then to try and find a way to actually get drug consumption rooms working, where the overwhelming evidence on the ground is the benefits they can bring to the communities in which they're faced, getting needles and addicts off the streets and shooting up on the streets and getting them on a path to where they have access and a start on the chance of actually getting on the route to recovery and to be able to do it in an entirely safe place. This is where we need the public health to be a priority for us. And recognising those difficulties, all I would ask of the Minister is that she learns, as I am learning about this issue as I engage with it, that she remains and the government remains open to all the evidence that is coming in from all around the world, all the different examples. And on drug consumption rooms, I would very gently suggest that the evidence from around the world is utterly overwhelming about their merits.
Thank you, Ms Ryan, for your agile and dynamic chairing of this debate, and congratulations to the Honourable Member for Inverclyde for securing it. It's a vital issue we need to address in this House. The Glasgow Safer Drug Consumption Facility and Heroin-Assisted Treatment Pilot Project was initially advocated by the Labour Administration on Glasgow City Council. It was led by Councillor Matt Kerr, Convener of Social Work at the time, acting on a recommendation from the Glasgow City Alcohol and Drug Partnership that this was a worthwhile and a highly evidenced method to improve the safety and hygiene of intravenous drug use in the city, and indeed it was supported cross-party and benefited from the wide support of, including the Honourable Member for Glasgow Central, who at the time was serving on Glasgow City Council. As many members may be aware, the issue of drug use and drug-related mortality in Glasgow is particularly acute, and it's a problem that necessitates radical and disruptive new approaches. Almost a third, 267, of all Scotland's drug deaths occurred within the Greater Glasgow and Clyde NHS Health Board area in 2016. Per million population, there are 283 drug-related deaths in Glasgow, but just 20 across the EU as an average. That means that Glasgow's drug death rate is an appalling 1,315% higher than the EU average and 329% higher than in England and Wales. Last year, 1,707 people died in the UK from a heroin overdose, yet no one has died from an overdose in a supervised drug consumption room anywhere in the world at any time. This is due to both the hygienic environment, medical supervision, and the readily available supply of life-saving overdose drugs like naloxone. According to the most recent estimates, around 13,600 people aged 15 to 64 in the Glasgow City Council area are problematic drug users. This represents 3% of the population, the highest prevalence rate of all local authorities in Scotland, and significantly higher than the Scottish average of 1.75%. In my constituency of Glasgow North East, there are particularly high levels of drug use in Postle Park and Springburn, two of the most economically deprived areas of the constituency, following 8 long years of brutal austerity, which only serves to drive up levels of despair and alienation in these communities, which is one of the main reasons why people fall into the pernicious trap of hard drug addiction. These areas have also been plagued by the brutal organised crime war between rival factions seeking to control the supply of drugs in the city. Drug consumption rooms offer hope in this otherwise bleak landscape of despair. They are used as an effective public health measure in the Netherlands, Germany, Denmark, Spain, Norway, France, Luxembourg, Switzerland, Canada and Australia, with 90 facilities currently operating in 61 cities. It is clear that drug consumption rooms are a worthwhile and practical measure to introduce to Glasgow. They benefit society, for example, by reducing drug-related litter and needle stick injuries, reducing the spread of disease and making our streets safer, as well as having significant health benefits for those who use drugs. Drugs consumption rooms significantly reduce fatal overdoses and needle sharing that can lead to infections, including HIV and hepatitis, by providing people with sterile equipment. They've also been shown to increase the number of people entering treatment programmes. Use of a safe space provides the opportunity to start engaging people, to build up trusting relationships with appropriate professionals, which supports them to take those first steps to dealing with their addictions. The benefits of DCRs have already been demonstrated elsewhere, yet attempts to set up the UK's first DCR has been blocked. This is despite the idea being supported by the British Medical Association. This decision is typical of a government that takes little heed of scientific evidence, of what works and what saves lives. This is primarily a question of public health, as has been said before, not one of criminal justice. I would therefore urge the government to adopt an open-minded approach, heed the consensus of all relevant parties and expert bodies in Glasgow, and reconsider amending the obsolete 1971 Misuse of Drugs Act to permit the piloting of the Safe Drug Consumption Facility in Glasgow in order to assess the opportunity it may bring to mitigate and solve the extensive harms we see caused by the current unregulated and unsafe drug consumption environment in my city.
Thank you very much, Mrs Ryan, and thank you for calling me and your patience throughout this debate with the many votes. I'm not going to repeat what other honourable colleagues have said, but I want to make some Bristol-related specific remarks, because I understand why people have an instinctive reaction that drug consumption rooms must be harmful because they appear to facilitate the use of drugs. I have to say to honourable friends who have doubts, we already have a drug consumption room in Bristol. It's called Bristol. It's called the square outside my office. It's called the doorstep into my office. It's called the blocks of council flats just on the side of my office. It's called virtually every part of the city centre. And the drug consumption that goes on there, and the drug litter that results, the harm, the visible harm, not just to drug addicts, but to bystanders, people who have no interest in taking drugs, but want their children to be able to play in the local playground. The harms caused by the existing drug consumption room are many and varied, and they hurt the most vulnerable and the very people that those of us on this side of the House are here to represent in particular. So I particularly want to encourage all colleagues to consider the use of drug consumption rooms. In Bristol, we have very high rates of injecting and of polydrug use, particularly crack cocaine mixed with heroin and then injection. But we're recognised by Public Health England, in fact, of having very high levels of complexity for people who use those drugs, and for the high levels of admission to hospital for drug-related harms. And that brings me on to another harm which is more widely shared amongst us all. That is the cost to the health economy of the existing drug consumption room regime. The total length of stay in the Bristol Royal Infirmary in 2015 to 16 for drug-related admissions was 2,758 days, with an estimated cost of drug admissions £1,103,200 in 2015 to 16. And that's when the Bristol Substance Misuse Needs Assessment, Bristol City Council, and I thank my colleague Jodie Clark for providing me with these figures. But hospital admissions specifically for injuries caused by injections accounted for 1,005 bed days, 36% of all drug-related stays. That's just 71 individuals, but they had an average stay of 14 days each. So that's over twice the average stay in hospital of 6.6 days for all drug-related admissions, and an estimated cost of in excess of £400,000. Now, Mr. I urge all colleagues to think, if we want to give our health service more money, we need to invest in drug consumption rooms. If we want to make our streets safer, we need to invest in drug consumption rooms. If we want to save the lives of those who have drug addictions, and I do, however unpleasant it is to have to step over a very aggressive, slightly frightening, or sometimes very frightening drug addict on my office steps, I don't want them to die. I want their lives to be saved, and I want the people who live in the blocks of flats near my office to be able to send their children out to play. And for all of those reasons, I argue that because nobody has ever died in a drug consumption room that was officially sanctioned and clinically run, I urge everyone to consider the drug consumption rooms we have at the moment and to support this.
Thank you very much, Ms Ryan. I'm very grateful to the honourable member for securing this important debate. In Glasgow city centre, Ms Ryan, there are around 500 people there or thereabouts injecting drugs on a regular basis. If you come to Glasgow, you probably won't see it, but for many of my constituents, this is a huge issue. Before I was first elected in 2007, the issue of discarded needles was pointed out by a resident, pointing me to a bin in a children's play park. I have an enduring horror, Ms Ryan, that eventually, sooner or later, a child will get pricked by a contaminated needle. It's a daily hazard for our council cleansing staff, and no one should have to live with that risk. The issue has never gone away in that time. It's simply moved around. And indeed, a constituent earlier on tonight, Andy Ray, told me he came back home to find 2 contaminated needles on his doorstep. As the member for Bristol West said, the problem is already there. It is on my office doorstep too. A constituent wrote to me over the weekend to say that in the 18 months that she's lived in her property, there have been countless times that I've seen people injecting drugs in the bin area, doorways and car park. They leave behind their needles, bloody wipes, spoons and bottles all over the area, strewn all over the ground, grass and hedges, as well as urine, vomit and blood on the ground. This is a nice, quiet residential area, home to people both young and old, families with children, students, people taking their dogs out. It's also in very close proximity to a children's play park directly across the road. And another constituent I spoke to on Monday told me of witnessing prostitution in bin shelters, of groups of people taking drugs under the stairs. I regularly walk around this part of my constituency, Ms Ryan, reporting needles as I find them. And after my surgery on Friday, amongst the usual places, I saw a young woman injecting herself behind a derelict building. There is no dignity for that woman. There's only desperation. This is the reality of life for intravenous drug users in Glasgow and the impact of their behaviour on residents. It is deeply damaging for everyone involved. Each of those people injecting drugs is someone's child, is loved by somebody, and we owe it to them to find a better way. There has been no means of dealing with this situation, and it's imperative that we do something different. Glasgow Health and Social Care Partnership concluded that the only way to deal with public injecting is to provide a safe, managed space for people to inject. In this way, we can also respond to the concerns of residents and businesses and meet the needs of a very vulnerable and marginalised population who do not engage in services. The Health and Social Care Partnership have a clear, well-thought-through proposal for a drug consumption room, and I would commend to the Minister, if she has not already read it, to take note of the report, Keep Taking Away the Chaos. Look at the evidence that they've gathered. I would like to pay particular tribute to Sakit Priyadashi for his work on this and to the commitment of Suzanne Miller from the Glasgow City Council and folk like Kirsten Horsburgh from the Scottish Drugs Forum for their advocacy of this important project. The Health and Social Care Partnership have done significant work to establish needs, protocols on how it would work, to listen to a range of health professionals as well as those who use drugs, and to find the means of funding it. It would be more than just a room, but a service, a bespoke service staffed by health professionals with a wraparound service to help people reduce their drug use and stabilise their lives. There would be an opportunity for those not currently accessing health services to do so, and for people to get assistance to rebuild their lives. The proposed Glasgow model is all about engaging with drug users to promote treatment, rehabilitation and social integration, as well as providing harm reduction services. The Minister must recognise, she must, that there is a cost in not taking action, in doing what we've already done. And this cost manifests itself in treating the latest HIV Hep C outbreak in Glasgow. It comes at the cost of emergency admissions to hospital. And the report mentions that over the last 5 years, there's been an average of 232 ambulance attendances in the city at suspected overdose just in Glasgow. There is a cost, as the member for Brighton Kempton mentioned, in doing this, and the Australian example will show how that cost can be saved. There is a risk to council staff, to housing association staff in clearing up needles, sometimes in their hundreds on sites, and as soon as they're cleared, those needles come back again and again and again. There's also the human cost, Ms Ryan. The cost of lives written off and wasted. And the member for Glasgow North East mentioned some of the figures. 867 drug deaths in Scotland in 2016 alone. We can't put a price on that, Ms Ryan. But for every family lost to addiction, every person lost to addiction, a family is bereft. Anyone's child, families for safer drug control support, drug consumption rooms. And I've listened carefully myself to people who have lost family members, and they were clear that drug consumption rooms would be a positive intervention, that at the very least their loved one would not risk dying alone in a filthy lane. Instead, they would be in a place of safety supervised by medical professionals, and as has been mentioned, there's not been one single death in a drug consumption room anywhere. The difficulty we have in Glasgow is that this project cannot go ahead without the permission of the UK Government, unlike in Ireland, where the Anna Liffey project and then Minister, now Senator Reardon, made a change to the law to allow it. The Lord Advocate can't pursue this, and an exemption from the Home Office has been refused. I have a letter signed cross-party from the majority of MPs in Scotland, cross-party, Ms Ryan, requesting leave for this pilot to go ahead. If it doesn't work, fine, but at least try. The status quo is not acceptable. I invite the Minister to come to Glasgow, to come to my constituency and see how people are living. See if she would like to put up with my constituents put up with every single day. See if she would find it acceptable for somebody she cared about to drop their trousers and inject heroin in their groin in a manky back court, surrounded by excrement and contaminated needles. I'd like to leave with a quote from the report from someone in recovery. The person says, "You need to think about it differently. That's where I think safe injecting routes and injecting heroin is. You take away the chaos, then you have a chance to work on the attitude."
I want to congratulate the member for Inverclyde for securing this important debate, but I also want to thank all members, not just for their contribution, but for sticking with us on this very disturbed debate, and congratulate Mrs Ryan on steering the ship through to a safe end. On this side of the House, we make no secret of how disappointed we were by last year's drug strategy. We waited nearly 2 years for it and, quite frankly, expected something more radical, more substantial, and certainly something with more funding. There is no amount of gloss that can hide the significant problems with the government's approach to drugs since they took office in 2010. Ideological and plagued with irresponsible cuts. All of today's members have expressed the truly shocking scale of the problem. The UK now has the highest recorded level of mortality from drugs use since records began. There are record numbers of deaths from morphine, heroin, and record numbers of deaths from cocaine use. There are more deaths from overdoses than traffic accidents, and an ever-increasing incidence of HIV and hepatitis transmitted via unhygienic injecting. Drug consumption rooms have operated in Europe for 3 decades, most notably in countries that have had a great success in reducing drug deaths than we have. And even if this government is misguided, they won't look at evidence from other countries. I would have hoped that they would have taken the advice of their own advisory council on the misuse of drugs. In 2016, in response to these unprecedented drug deaths, they recommended that the government consider the introduction of drug consumption rooms. I believe the response was that, and I quote, "It is for local areas in the UK to consider with those responsible for law enforcement how best to deliver services to meet their local population needs." Now, I agree that the local authorities are best placed to deliver such services. However, when responsibility for alcohol and drug treatment was transferred from the NHS to local authorities in 2013, this signalled the most significant and problematic change to funding. And whilst I'm not criticising our overstretched local authorities, the transfer of responsibility brought an end to ring-fence budget for drug treatment, resulting in reduction of services. In an ideal world, no one would take these harmful substances, but we don't live in an ideal world, and therefore we cannot base life or death decisions on ideology. We have to go with what works. And if the evidence is clear that these drug consumption rooms prevent overdose deaths and the spread of disease, then we at least need to trial them. Glasgow was set to do this until they were blocked by the government. Now, I know my honourable friend's main purpose for calling for this debate is to call for devolution of drug legislation to Scotland. But the drugs problem is UK-wide, and we need a UK-wide solution. I, like many, am uncomfortable with the uncertainty we often find ourselves in when it comes to drugs and the law, between legal highs, more widespread drug use, changes in legislation in other countries, decreased prosecutions for lesser drug offences, and even festivals like Glastonbury offering drug testing facilities. We have been sending mixed messages for far too long. We must address this before we are to move forward in a meaningful way. On this side of the House, we are clear. The ever-increasing spread of disease and record number of deaths from drug use is unacceptable. It must be dealt with as an urgent public health issue. The government must take responsibility for this and must review legislation as priority.
Thank you, Madam Chairman. It's a pleasure to serve under your chairmanship, and I join others in congratulating you on your skillful navigation of the votes and timetabling. And I'm also grateful, actually, to the Honourable Lady opposite for giving me a little extra time to respond in what is a very complex debate. I thank the Honourable Member for Inverclyde for raising this debate and for his obvious passion and commitment to this topic. I'm going to start, if I can, from a position, I hope, of agreement. Nobody in this House, in this place, wants people to become addicted to heroin or crack cocaine or any of these drugs. Nobody wants that. And we are all grappling with the ways in which we can fight that drug battle, help addicts, ensure that young people aren't led on to the wrong paths by gangs and so on into taking drugs. We want to rid our country, if we possibly can, of these awful substances. But like every other country in the world, and as indeed my honourable friend said, it is incredibly difficult, and nobody has yet got the answer. Just to be very clear from the start, I don't agree, the government doesn't agree with the honourable gentleman's suggestion. We have no intention of introducing drug consumption rooms, nor do we have any intention of devolving the United Kingdom policy on drug and the classification and the way in which we deal with prohibited drugs to Scotland. It is drug barons do not respect geographical barriers or boundaries, and I dread to think what would happen if we devolved our UK-wide policy in the way he suggests, because that would then create an internal drug market within the UK, adding further to the pressures on law enforcement. And the honourable gentleman is looking a bit askance at me. He knows that my background, I used to prosecute criminals for a living. I prosecuted drug gangs. I prosecuted international drug gangs, so I know whereof I speak. There has been, if I may say, a certain naivety in some of these arguments as to what these international gun-toting criminals will do if we, the UK, regulate prohibited drugs. They are not going to run away and study university degrees, in a moment please, and lead law-abiding lives. They are going to find ways of undercutting the regulated market that presumably the honourable gentleman is calling for with prices. They will find ways of getting to their addicts. They will still continue their awful trade. It's just that under the honourable gentleman's model, as I understand it, it will be the taxpayer who's helping to pay for some of these drugs that we are against. I give way.
Imagine the people that were going to drive out of business are going to do the same things they did in the 10 other countries where we introduced. I'm talking drug consumption rooms here to help people with addiction problems through that phase of their life. 90% of people who use drugs in a recreational fashion do not have an addiction problem. We're talking about people with an addiction problem and a compassionate and humane way to help them through that. That's what DCRs are about.
Because their purpose is not recovery. Their purpose, in fact, is to provide a place where illicit drugs that have been bought in the local area are then consumed in a place funded either by the taxpayer or by charities. That is not... recovery is an optional part of that usage. It is not the sole purpose of it, which is very different from our drug strategy. I'm going to come on to that in a moment, but let me first of all deal with the international comparators, because much has been made of the evidence from abroad. And again, I accept that this is there is no clear answer here, but I'm obliged to put in context some of the evidence that has been put in this chamber by the Honourable Member for Inverclyde and also the Honourable Member for Bristol North East. 10 countries have DCRs. 7 of them are in the European Monitoring Centre for Drugs and Drug Addiction, and in those 7 countries, 78 facilities exist. So when we're talking about changing our national drugs policy, we have to be very clear as to the limits of the evidence on which the Honourable gentlemen opposite are relying. The Honourable gentleman mentioned some of the countries. Canada has kept its provider Insight, not because of the evidence that the services provided by Insight work, but because the users of Insight brought 2 court actions, and the Canadian Supreme Court, their equivalent, ordered the minister who wanted to close them, ordered them to grant an exception to Insight in order to respect the constitutional rights of facility users and staff. Now, I read that with my legal hat on, not as an endorsement of the effect of these DCRs, but as a constitutional issue. In terms of France has not agreed to use these rooms permanently. They are running a pilot project for 6 years. And in terms of Spain, the evidence I'm given by those who sit behind me is that there is 1 room open in Catalonia for 1 hour a day from Monday to Friday. Now, when we hear that there have been no deaths in DCRs, and I accept that, we have to understand the context in which these rooms are operating. And if I may suggest, 1 hour a day from Monday to Friday does not support a great deal. We're not talking about the majority of heroin users in that town in Catalonia. The honourable gentleman in Bristol North East talked about there being no deaths in Sydney, and I was grateful to my honourable friend for clarifying with him that when he talked about deaths, he was in fact just talking about deaths, there being no deaths in DCR, not that the introduction of these DCRs have stopped deaths from heroin in Sydney as a whole. We don't know, because nobody's done the research yet, on what happens to addicts when they leave DCRs. DCRs are not residential. Addicts are there for a number of hours. We do not know what happens when they leave those clinics, when they walk down the street. We do not know the impact. And also, as we've heard, they're not there every single day. This is not a regular form of treatment, which is precisely why we are looking at the... I'll turn now, if I may, to the drug strategy, because recovery is at the heart of the government's drug strategy. We have brought together health, education, all of the relevant departments to tackle drug addiction, look at tackling also the illicit trade in drugs and of the answers within the community, including with the police. But recovery is at the heart of this. And I'm sorry to hear of the experience in Scotland. Pleased is the wrong word, but... Oh. Thank you, Madam Chairman.
One minute? No.
Sorry. Time is up.
We need another debate. Backbench debate, thank you.
I let it run on 20 seconds, but I couldn't...
No, thank you. It's just too much.
If the clock ticks
Sorry?
over, Mr Speaker would want to know...
Right, I'm so sorry. I'm so sorry. I've got Bristol North East. Forgive me. I'm so sorry. Well, I ought to correct Hansard then, because Brighton and Kemp Town. Please forgive me. Yes, forgive me.
Well, that was a very strange afternoon, wasn't it?